So from your perspective, both Sam and Rahul, since bulk of our listening audience are South Asian, did you see a higher incidence of COVID infection amongst the South Asians?
So, I think that what I'd mentioned earlier, first of all, and thank you, the pendulum, as Rahul said, is kind of swung back to near normality, and that whole fear factor is now starting to decline thanks to vaccinations and understanding of disease, and like I said, media and other factors. A lot of reading. Most of our folks are educated. 95% of our population is educated. They understand the risks and so on and so forth. And yes, we were living more in fear than anything else. And specifically to answer your question, I think that people were just fearful to come out to the emergency rooms, fearful to kind of get appropriately treated and so on and so forth, and fearful to see their doctors. But I think that there was no significant increase of actual risk between subpopulations that we saw, across the board, at least in our limited population on the East Bay. Now, again, if you look at it globally, the pandemic was devastating in different parts of the world globally, and I can't really speak for that, but I can tell you that locally here in the East Bay, we did not see any particular increase or rise. I think our South Asian patients were much more, let's put it this way, vigilant compared to some of the non-South Indian patients, and more fearful perhaps, and very cautious, exceedingly cautious. So I did not see any increase in our practices, at least here locally this way.
I'll take it a step further. Since you noticed some delay in people seeking help, were some of the complications that you saw a result of the delay in seeking care, or was appropriate care not given in a timely manner?
I think both. So that's a good question. I think that because we were not able to, see patients, telehealth was still kind of in its infancy. We were not able to even capture the right audience, if you may, or capture or have contact with a lot of people. People just went into this whole period of dormancy. And all of a sudden, I remember, March 15th coming on, and then our patient volume, which was, let's say, in the outpatient clinic, we're seeing 25 or 30 patients a day, was down to maybe 1 or 2 or 3 or 4 patients a day, because they were either so sick, or they were like, I have to see my doctor for one reason or another. But they were not coming in for forget about routine checks. They were not even coming in for serious blood pressure problems, for serious problems related to their heart disease for that matter, and so on and so forth, to get an EKG with chest pain for that matter. And yes, that's the outpatient setting. And we also saw a drop in the ER visits, and we saw a rise in myocardial infarction. We saw a simultaneous significant rise in heart disease that was catastrophic. And so in having privileges at one of the local hospitals, we saw that the patients who came in were sick to the point where they ended up getting cardiovascular catastrophe, shock, and those kinds of patients who were on these life-saving type of machines were basically being treated rather than the common garden variety, generic myocardial infarctions or heart disease that we saw normally coming into the emergency room. And perhaps Rahul can shed light because he sees it from the other side.
Yeah, I think I totally agree with and echo what Sam is saying. We see it from slightly different, but obviously coalescing perspective. We too, as a result of noticing that dip in referrals, patients coming in to see primary physicians, primary cardiologists, and therefore them not coming in to see us, but also the inpatients who are avoiding coming in. Now we're seeing it as kind of a surge of patients coming in who are waiting and can no longer wait or feel it's safe to come back. And what we're noticing is that their pathology is far more progressed than, say, they would have come in pre-COVID. And in some instances, that's okay. They're still in that window where it's appropriate to treat them and salvage. In unfortunate circumstances, it's too late. And I'll share a rather poignant and very contemporary example just that happened yesterday. I got a call from a referring physician from Santa Maria down south who was trying to transfer a patient that had a severe aortic stenosis, a narrowing of one of the valves that leads from the heart. Now, normally, once we identify that sort of pathology, the patient is referred in, they're seen by us, and we choose an appropriate treatment strategy. And we try and treat those patients very rapidly because we know with that sort of a disease state, 50% of patients will die within 12 months untreated. So it's relatively urgent. Now, as a result of COVID, this patient was diagnosed. They elected to wait. They waited 6 months before returning to see their physician, who then suggested that they should be treated. They were discharged home, and they presented a week later in florid heart failure. Now they were admitted as an inpatient. So now you fast forward 6-7 months, and that patient would have been treated as an outpatient in stable condition. They're now very sick. They're in hospital. They're on drips to keep their heart pumping. They're now calling us to transfer that patient very urgently in a helicopter. I brought the patient in. We transferred them. We took the patient to have a CT scan, which is necessary as part of the workup to put a new valve in a minimally invasive manner. And unfortunately, the patient actually had a cardiac arrest inside the CT scanner and died. Now, that's something that would have almost never happened pre-COVID because that patient would have been seen, referred, and treated within a matter of months. And so I think that's something we see.
Delayed care.
Delayed care.
Yeah, there was an interesting report out of UK today, actually, that they saw a higher incidence of COVID-19 amongst patients with pre-existing heart disease. So what comes first? Is it heart disease or COVID?
I think the pre-existing heart disease is definitely out there because COVID just adds flavor. It's kind of like an icing on a cake, So if you have a bad cake to start with and you put icing on it, it just makes it worse.
What kind of heart problems do asymptomatic and mildly ill COVID-19 patients have?
I'll take that. That's a great question. It's $1 million question, and whoever asked this, thank you. So there's been new literature out in the last maybe 3 to 6 weeks. I would say there was one very elite article by Eric Topol, one of my friends and colleagues from the Scripps Clinic, and Rahul, you probably know him well. And Eric had eloquently pointed out that nearly a third of patients that have even the mildest symptoms will have a contractable, like a long-standing comorbid type of an event with chronic fatigue, chronic, even mild symptoms of shortness of breath, heart failure. And eventually, we're still studying that. We don't know, perhaps 2, 3, 4, 5 years later, we'll know more about it, whether they will have COVID-related cardiomyopathy. And that's pretty serious. And so how do we check that? Eloquently, it put it in this article saying that, of course, if it's a fancy center or a large center that does a lot of MRIs, MRI is the best way to check this. Next to that, the common cardiologist like myself or a community cardiologist like myself would basically check it in the office with an echocardiogram or serial echocardiography procedures to see where we are, and perhaps a stress test to see where we are with the functional capacity of the heart. That's how we would check that. But certainly we're still learning. That's the plan.
So are these long-term issues that we need to be concerned about?
Absolutely. And I think we don't know the answer to that. And I think it's too early, but I think you have to kind of take that seriously. I follow every single one of my COVID patients, ever since they've actually got the bug, regardless of the age. Of course, age matters and immune status matters. Pre-existing conditions matter, like the ones that I talked about and that Rahul had talked about. But certainly, I think that has to be taken into consideration. And of course, certain changes in diet, exercise, reconditioning your body. It's kind of like the flu. People, if you get recurrent flus or if you get recurrent autoimmune type of disorder, you can still come out of that if you have if you change your immune status by changing your diet, changing your, modified plan of activity and so on and so forth. Rahul, please interject here. I'm getting too excited about this.
No, I think everything you're saying is very spot on and very relevant. And, I encourage all my patients, regardless of, whether there is an active issue or resolved cardiac issue, to have a cardiologist that you see regularly, and hopefully you're able to find someone who provides as comprehensive care as Dr. Suri does. But I encourage all of you who are either yourself or your family members have cardiac problems, establish care with a cardiologist, because it's important. A lot of what Sam is saying is focused on the preventative aspect.
Great. Thank you. Sam, since you mentioned diet, there's a question out there. Mediterranean Indian diet suggestions.
Right, right.
The
So I
heart.
think I asked Som to upload a diet. It's called dietbrrp.com. That would give everything you need about the Indian Mediterranean diet. But basically, it's a combination of legumes and fruits and more vegetarian type of salads that we have in India that we make of our own. Like the tomatoes with cucumber and some people like raw cabbage, things like that. I mean, those are the things that sort of will be part of your diet. And again, don't forget the rotis. They are important, but just in moderation, maybe 1 or 2 a day. They say 2 to 3, but I think it's 1 or 2 a day. And dals do help. That's a form of legume. That's good.
Well, in CWC, over the past couple of years, we've championed several things, preventative measures for wellness that included yoga, meditation, and certain types of exercises. Is there something specific that you would recommend for patients who are either recovering? It doesn't have to be COVID related, but heart in general.
Right. So meditation is key. I think meditation, and there are different studies that have been done. There's no average, but I think that it's clear that about 30 minutes, if you can spend meditating in a day, that certainly brings your mental, this mind, body, soul approach, which I think makes a lot of sense. That really, brings everything in alignment. I think exercise, we all know the American Heart Association, 150 minutes, which I think is still inadequate per week, but it should be a little bit more. I push my patients to do perhaps 200 minutes a week or 250 minutes a week if possible, because if you have the ability to walk, then you should be able to walk. That's what I tell everybody. And you should be able to walk that 10,000 steps, maybe 12,000 steps if you can push it. And then don't eat late. That's the key thing. Don't eat like today. I'm going to eat late because it's a Friday, but I would not eat after 6 o'clock. I mean, my wife says you start eating too early, but 6 o'clock, 7 o'clock at the latest, that's the key thing, and start your day as a king and end your day as a pauper in terms of your diet. Okay, so start big, eat a good breakfast, very good breakfast, eat a mediocre type of lunch, and then have a pauper type dinner. That's the real strategy behind it.
Well, there's actually a study out of India where they studied patients using yoga in the face of an acute infection. And that included patients with COVID, from what I understand.
Okay.
And supposedly documented increased immunity, less stress, and more efficient pulmonary rehab. So there's probably some merit to it. Rahul, your thoughts on that?
I think that's very interesting. There's been a lot of studies, even if they're observational, to show some of the benefits of not just what Sam is referring to in terms of mindfulness, but also the impact of yoga, breathing, particularly breathing therapy. Those patients tend to have a better respiratory reserve. And we know that those with any pre-existing lung issues have a higher risk of not just contracting COVID, but the complications of COVID. And then also, I think relevant to the South Asian communities, there's been a lot of interest in the role of turmeric as an antioxidant and an anti-inflammatory. And we know that a lot of the sequelae of COVID are related not just directly to the viral infection, but also the inflammatory response. And there's, it was quite interesting to see the price of turmeric shoot up during the pandemic in a lot of the supermarkets as a result of that. So I certainly think there is a little bit of merit to a lot of what you discussed.
Great. Here's an interesting question. After vaccination, does a person with heart comorbidities have the same level of impact to heart if they get exposed to COVID?
We're still learning, and there's still, remember that after you get vaccinated, you're not protected for at least 2 weeks. While the vaccine is, close to 97, 98% effective, one can still carry the virus and therefore give it to someone else. But yes, theoretically, you should be protected from contracting the virus, assuming that the virus doesn't mutate or there are no other forms. Now, remember, if you have underlying cardiovascular disease, you're at risk of all of the effects of that. But also, there's not just COVID, there are many other respiratory viruses. In fact, a lot of patients with COVID can have coexisting viruses. And so remember that the vaccination against COVID is just specific to that. And so I think that while it protects you, and like Sam said, it's better than not being vaccinated, it's certainly not a cure or protect all.
Great.
Thank you.
Rahul, in terms of your interventional cardiology, have you seen any sequelae of COVID that has resulted in, let's say, increased problems with heart valves and so forth that required intervention?
Great question. I think that we haven't had enough time to truly ascertain the effect on a population level. Anecdotally, like case to case, I think that a lot of the patients who had overwhelming or fulminant infection with a lot of cardiac issues, they were so sick in the acute setting that it was really difficult to see how much of it was due to the acute illness and being in ICU, being on a ventilator, and all the complications of that versus a more intermediate to longer term. I will say that what we're seeing in clinic is the patients who had some degree of underlying cardiovascular disease who then got COVID seem to have a more rapid progression of their either underlying coronary artery disease in terms of symptoms, or in terms of I guess, their underlying reserve in response to their disease. So it's not to say that their, for example, valve leak or valve narrowing got worse because of COVID, but rather what I'm seeing is that those patients and their physical capacity and reserve to manage with those conditions has changed, in that COVID has actually taken away a lot of their reserve. So where before getting COVID, they could manage with that degree of leak or narrowing of an artery or a valve, now they struggle a lot more. Their exercise tolerance is less, their fatigue is greater, they're more symptomatic. I think that's what I'm noticing.
After the vaccination, is there any chance to get COVID-19 with pre-existing conditions such as diabetes, cholesterol, and high BP?
Well, I mean, after the vaccination, as Rahul had indicated, you're basically 98, 99%, depending on what study you're reading, you're protected from developing symptomatic, disease that would assure you the either hospitalization or death. But you still have a 6% risk of developing problems that would be quite serious. The Pfizer vaccine of late, and I'm not, an infectious disease expert in any way, but I've been reading about this, as is now the Moderna, and Moderna is doing more studies on this. The initial Pfizer vaccine has been able to show that even some of the asymptomatic infections are reduced down to 6%. So, that's pretty good. That means, you can safely not wear your mask if you're sitting 6 feet away with another group of people that have been vaccinated. And I usually tell my friends that we'll just limit it to a sixsome. That means my wife, myself, or my friend, myself, and like 4 other people at the most. That's it.
Any thoughts on the AstraZeneca vaccine being sort of banned in some of the countries because of?
Yeah, that's a very important, very good question, and I think this pertains to cardiovascular disease, and I'll tell you why. Because the vaccine in itself, was the way it was manufactured, and the way the attenuation occurred in this virus, in this particular vaccine, it has an increased propensity for development of serious clots. And sort of like a coagulopathy that occurs, or a procoagulant state that occurs in COVID disease in itself. So it sort of is similar in terms of development of hypercoagulable state. And that in itself can be posing risk for strokes in particular, and also certain cardiovascular disease, including heart attacks. So that is why the Nordic countries, particularly Norway and Sweden and so on, have restricted any use of this vaccine at this time. And it's not the entire vaccine, it's that batch that was offered to them. So they're still utilizing it in parts of Asia, and in particularly in South Africa, because it may have been a different batch, but at least at this point, that's the knowledge we have from the information that we've got, not only from media, but in reading medical literature.
We'll get to a couple of more questions before we wind up. Here, this is probably not COVID related, but to the cardiologist, what's your suggestion for travel by air for a short journey of about 1 hour?
Rahul, go take that one. I'm good. That's kind of easy one.
Sure.
Patient has had heart bypass surgery and heart damage. I don't know exactly what heart damage means, but anyway, post-CABG patient.
Sure. So, I mean, I'm assuming this is not a immediate post-surgery or immediate post-procedure, but in general, you're safe to travel, even long-haul air travel, so long as you have, you're not unstable. So just because you have cardiac disease or a history of bypass or stents does not preclude you from traveling, even long-haul air travel. Of course, if you've recently had a procedure, depending on how invasive the procedure is, generally the rule of thumb is 2 weeks, and there are actually guidelines around this based on the type and the degree of invasiveness of the procedure. I certainly advocate at least 2 weeks after a procedure before you can travel. And then if you have a chronic condition, again, it depends. If, for example, a patient who has a lot of heart failure, a lot of breathing problems, long haul travel is not recommended for them, but short travel is certainly appropriate, versus someone who has very little in the way of symptoms and really has a stable chronic heart disease. So I think it's very individualized, but if you've previously had bypass and you're otherwise well and don't have issues every day, by all means, a 1 hour flight is no problem at all.
Excellent. Thank you.
Great, thank you, excellent. Any graded exercise program that you guys recommend for someone who's recovered from mild COVID?
I can take part of that question. The answer is absolutely. I think the way you have to do this is if somebody's not exercising, the first thing to do is to count your steps. When you walk, walking is the single best exercise, regardless of what anybody says, because you get enough aerobic and you don't have to worry about, and you get enough isotonic exercise. You don't have to worry about the isometrics. The second and third thing is that you have to be, if you're vigilant enough and you can get your 30 minutes in 5, 6, 7 days a week in a graded response gradually, if you're able to ambulate reasonably well on a flat surface, preferably, that would be the way to start. And then perhaps a slight incline over time, and then get used to doing 10,000 steps minimum every day if you can over time. Of course, it all depends on your oxygen saturation. If the oxygen saturation is low to begin with and gets even lower, like under 90% when one exercises, or 92% precisely when one exercises, then you have to be a little bit more cautious. So I do tell people who've had COVID, especially in the last 2 to 4 weeks prior to that, preceding that you should carry a sat meter, or if you have any other underlying condition, for example, asthma or COPD, or as we call it, chronic lung disease, or even heart failure associated with COVID-related problems, to be a little bit more careful and always carry an oxygen sat meter with you.
So I want to thank you both for your time and the excellent presentations that you both made. I enjoyed it. I'm pretty sure the audience enjoyed it too. We really appreciate it.